Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 448 of our pharmacotherapy series, which majors in colorectal cancer. The next case reads: KTM is a 64-year-old man treated approximately 2 years ago with adjuvant chemotherapy for colon cancer, which he tolerated well. On a routine surveillance visit, his CT scan shows a colon mass, 2 discrete liver nodules, and a nodule in the left lung that are consistent with metastatic disease. The biopsy of the liver was positive for adenocarcinoma of the colon. KTM is feeling well and has been asymptomatic. No cytogenetics on the tumor was performed at this time. KTM's CBC and chemistry values were as follows. His WBC count is 7.8 times 10 power 3 cells per microliter. A hemoglobin of 13.2 grams per deciliter. A platelet count of 252 times 10 power 3 cells per microliter. A serum creatinine of 1.1 mg per deciliter. A blood urea nitrogen of 15 mg per deciliter. An aspartate aminotransferase of 28 units per liter. An alanine aminotransferase of 35 units per liter. An alkaline phosphatase of 135 units per liter, and a total bilirubin of 0.8 mg per deciliter. KTM's carcinoembryonic antigen concentration was 22 nanograms per milliliter. So my question to you reads: what is the role of chemotherapy now that KTM has a metastatic recurrence? Metastatic colorectal cancer affects a substantial number of patients. Approximately 20% of patients have metastatic disease at initial presentation, and approximately 50% of patients diagnosed at any stage will eventually develop metastatic disease. Significant treatment advances have been made over the last decade for cases of advanced colorectal cancer, such that the median overall survival is currently over 2 years in treated patients. Treatments tend to include combination therapy, a fluoropyrimidine plus either irinotecan or oxaliplatin, for good performance status, abbreviated as PS, patients, and monocytotoxic therapy, fluorouracil or capecitabine or irinotecan, for poor performance status patients. Further, agents directed against the vascular endothelial growth factor, abbreviated as VEGF, e.g., the monoclonal antibodies, bevacizumab and ramucirumab, and the soluble decoy receptor, ziv-AF-libacept, or against the epidermal growth factor receptor, abbreviated as EGFR, such as cetuximab and panitumumab, both monoclonal antibodies, can be added to the chemotherapy backbone in qualifying patients. Given the number of agents currently available and that we tend to talk in terms of regimens, i.e., combining agents together, in the treatment of metastatic colorectal cancer, it is imperative to consider which agents have greater synergy and less toxicity when combined and how best to sequence these agents, because patients will most likely remain on some type of therapy throughout their disease course. Irinotecan has been studied combined with a bolus regimen of fluorouracil and leucovorin, abbreviated as IFL, and an infusional regimen, abbreviated as FOLFIRI, as well as with carfacetarbine, abbreviated as XELIRI or Capiri. In general, both IFL and CAPIRI, XELIRI have fallen out of favor because of exorbitant toxicities and less efficacy than FOLFIRI. Oxaliplatin, as in the early stages of colon cancer, has been studied with both infusional fluorouracil and leucovorin, abbreviated as FOLFOX, or with carfacetarbine, abbreviated as XELOX or CARPOX, in the metastatic setting. Both strategies of combining oxaliplatin with a fluoropyrimidine in the metastatic setting are equally efficacious, with again, the main differences being the toxicity profile of carfacetarbine versus fluorouracil, leucovorin. The decision to start with an oxaliplatin-based regimen, such as FOLFOX or XELOX, or an irinotecan-based regimen, such as FOLFIRI, tends to reflect differences in clinical practice rather than clinical outcomes, because sequencing studies and the results of multiple individual studies seem to indicate that both regimens are equally efficacious in the first line. With the optimal sequencing of these regimens remaining unclear, the decision regarding the choice of combination therapy for first or second line therapy is based on prior therapy, quality of life, pre-existing toxicities, comorbid conditions, and clinical practice where the patient is first seen. Surgery is typically not an option in extensive metastatic disease. In the past decade, biologic therapies targeting vascular endothelial growth factor, such as bevacizumab, ziv-af-libacept, and ramucirumab, and epidermal growth factor receptor, such as cetuximab and panitumumab, have been incorporated into the treatment of many cases of metastatic colorectal cancer. In addition, regorafenib, a multi-targeted, orally administered tyrosine kinase inhibitor, abbreviated as KI, and trifluridine, tipiracil, also designated as TAS-102, an orally administered cytotoxic agent, have both been shown to modestly improve overall survival over placebo as monotherapy in the salvage setting. We will now discuss targeting vascular endothelial growth factor. Bevacizumab is a humanized monoclonal antibody that binds to the ligand of the vascular endothelial growth factor 2 receptor, vascular endothelial growth factor A. The addition to bevacizumab in the first line to oxaliplatin-based regimens FOLFOX or XELOX or irinotecan-based FOLFIRI has been shown to increase progression-free survival, abbreviated as PFS, versus chemotherapy alone, and overall survival was also improved, although this seems more pronounced with FOLFIRI than with oxaliplatin-based regimens. Bevacizumab, when continued beyond progression in the second-line setting, with either FOLFOX or FOLFIRI has shown a modest survival benefit of the addition of 1.4 months versus placebo. Two newer anti-vascular endothelial growth factor agents, ziv-af-libacept and ramucirumab, have also been shown to provide a survival benefit to the chemotherapy backbones with which they were studied. However, the differences in how they were studied is important to note in order to apply them in clinical practice. Ramucirumab, a fully human monoclonal antibody that binds to the extracellular domain of the vascular endothelial growth factor 2 receptor, has been shown to increase survival versus placebo by 1.6 months when combined with FOLFIRI in patients that progressed on bevacizumab plus FOLFOX. ZIV-AF-LIBA-SEPT, a soluble decoy receptor that targets the ligands vascular endothelial growth factor A, vascular endothelial growth factor B, and placental growth factor, abbreviated as PIGF, has also been shown to increase survival versus placebo when combined with FOLFIRI in the second-line setting after progression on oxaliplatin-based therapy. However, in the patients that had previously received bevacizumab, this benefit was less pronounced, around 0.8 months. And now we will look at targeting the epidermal growth factor receptor. The EGFR receptor is overexpressed in the majority of colorectal cancers, making it an attractive target for therapy. However, 56% to 63% of these tumors will possess a downstream mutation in the RAS oncogene, a predictive biomarker for a lack of response to epidermal growth factor receptor targeted therapy. Therefore, prior to consideration of epidermal growth factor receptor therapy in any metastatic colorectal patient, analysis must be undertaken to determine RAS status, with epidermal growth factor receptor therapy only being offered to those that are RAS wild type. Cetuximab is a chimeric monoclonal antibody against the extracellular domain of epidermal growth factor receptor. It has been studied in the first line with both FOLFIRI and with oxaliplatin-based therapy and is currently approved in combination with FOLFIRI only in the first line for patients that are RAS wild type. It is also active as a single agent or in combination with irinotecan even in patients with irinotecan refractory malignancies. Panitumumab, a fully human monoclonal antibody also targeting the extracellular domain of epidermal growth factor receptor, has been shown in RAS wild-type patients to improve overall survival in the first-line setting when combined with FOLFOX and in the second-line setting combined with FOLFIRI in patients that had progressed on an oxaliplatin and bevacizumab-containing regimen. It may also be used as monotherapy in patients that have progressed on oxaliplatin and irinotecan-based therapy. The trials of combining cetuximab or panitumumab with bevacizumab and chemotherapy have resulted in a decrease in progression-free survival and increased toxicity, so this combination should not be utilized. The choice of whether cetuximab or panitumumab is chosen as the anti-epidermal growth factor receptor agent is more a matter of local practice and differences in prescribing habits than being data-driven. They have been compared to each other in the salvage setting as monotherapy and are considered equally efficacious, with the main difference being a slightly higher rate of infusion reactions with cetuximab versus panitumumab, that is 13% versus 3%. In addition, there is currently no data to support the use of one of these agents after proven progression on the other agent. KTM has stage 4 colon cancer with metastasis to the liver and lung. The goal of therapy for KTM is prolongation of survival. At this point, KTM's cancer is not curable. Because tumor cytogenetics was not performed, KTM's RAS status is unknown. Therefore, epidermal growth factor receptor monoclonal antibody at this point is not considered a first-line treatment option. KTM should receive combination chemotherapy. Standard first-line chemotherapy involves a fluoropyrimidine in combination with oxaliplatin or irinotecan. Addition of bevacizumab to this regimen will further improve response rate and survival of KTM in this case, KTM is scheduled to receive the FOLFIRI plus bevacizumab regimen, which is given every 2 weeks. He will receive this chemotherapy regimen until disease progression. The FOLFIRI plus bevacizumab is given as bevacizumab 5 mg per kilogram IV for 10 to 30 minutes, leucovorin 200 mg per meter squared IV for 2 hours, irinotecan 180 mg per meter squared IV for 90 minutes, and fluorouracil 400 mg per meter squared given as a bolus, which is then followed by 2,400 mg per meter squared infused for 46 hours. We will now discuss immunotherapy for MSIH tumors. Immunotherapies have broadly made their way into different areas of oncology. However, until recently, colorectal cancer patients did not seem to benefit from these agents. 2 new drugs have been approved in metastatic colorectal cancer, specifically for patients with mismatch repair deficient tumors. Pembrolizumab, given as a single agent, was granted accelerated approval from the FDA on May 23, 2017 for treatment of metastatic colorectal cancer that is deficient in MMR and has progressed following treatment with a fluoropyrimidine, oxaliplatin, and irinotecan. Nivolumab, given as a single agent, was granted accelerated approval for this group of patients on July 31, 2017. Approval for both was based on tumor response rate, and as a condition of accelerated approval, further studies are required to confirm the clinical benefit of these 2 agents for this indication. However, while promising, patients with mismatch repair deficient colorectal cancer represent only a small subset of patients with metastatic disease. That is approximately 3% of the population versus approximately 22% of those with stage 2 colon cancer and approximately 12% of those with stage 3 colon cancer. We will now briefly discuss hepatic metastases. Colorectal-related metastases most commonly arise in the liver, and 20% of patients are diagnosed with synchronous liver metastases. Surgical resection, if possible, offers the potential for long-term survival in colorectal patients with isolated liver metastases. Further, because liver metastases derive most of their blood supply from the hepatic artery, direct administration of anti-cancer drugs into the artery can provide high drug concentrations to the area of tumor involvement and, as such, has been an area of therapeutic interest. Hepatic intra-arterial administration of floxuridine, abbreviated as FUDR, a fluoropyrimidine with a high first-pass metabolism, offers the ability to deliver chemotherapy to the liver metastases with virtually no systemic exposure or side effects. However, the hepatobiliary toxic effects of hepatic arterial FUDR include elevations in AST, alkaline phosphatase, and bilirubin levels, and in severe cases can evoke changes similar to sclerosing cholangitis. To prevent this, FUDR is infused with dexamethasone for its anti-inflammatory effect. Hepatic intra-arterial therapy is usually restricted to treatment centers that have expertise for this modality. The major limitation for such treatment is that undetected metastases located elsewhere would not be exposed to the agents as they would after systemic administration. Further, there is a paucity of data related to giving FUDR via the hepatic artery in combination with systemic chemotherapy, but, from the limited data available, it does seem that co-administration with systemic bevacizumab may increase the risk of biliary toxicity. 14 days after receiving FOLFIRI plus bevacizumab, KTM presented to the emergency room complaining of fever of 101.2 degrees Fahrenheit. On further evaluation, KTM was identified as having febrile neutropenia with a WBC count of 1.2 times 10 power 3 cells per microliter and an absolute neutrophil count of 650 cells per microliter. He was admitted to the hospital for treatment. So my questions to you read: is there an accurate method for predicting this outcome in KTM? Can KTM continue to receive this therapy? Recent discoveries in the field of pharmacogenomics have identified several important genetic variations, that is polymorphisms, that partly account for interpatient variability regarding the tolerability and efficacy of some drug therapies. Dihydropyrimidine dehydrogenase, abbreviated as DPD, is the rate-limiting enzyme responsible for the breakdown of fluorouracil to dihydrouracil and eventually to fluorinated SS-alanine. The cytotoxic effects of both fluorouracil and capecitabine can only occur after conversion to active metabolites, and the amount of fluorouracil available for this conversion is determined by the extent of its breakdown. Dihydropyrimidine dehydrogenase is subject to genetic polymorphism, which can lead to a deficiency in its activity. Approximately 3% to 5% of the population will have a partial dihydropyrimidine dehydrogenase deficiency, with 0.2% of the population estimated to have complete loss. While several tests are currently available that attempt to identify this deficiency, no single test has the specificity and positive, negative predictive values to accurately predict a true lack of enzyme activity. Further, most studies to date that evaluated testing for dihydropyrimidine dehydrogenase deficiency prior to administration of fluorouracil-based therapy only addressed reduced toxicity, but not whether dose reduction was actually necessary. Uridine diphosphate glucuronidyltransferase, abbreviated as UGT, enzymes are responsible for the glucuronidation of bilirubin and other endogenous substrates as well as drugs and other toxins. The enzyme UGT1A1 is responsible for the glucuronidation of SN38, the active metabolite of irinotecan. Reductions in glucuronidation and accumulation of SN38 are associated with greater toxicity. Of the known genetic polymorphisms of UGT1A1, one polymorphism in particular, UGT1A1*28, has been associated with decreased glucuronidation and therefore prolonged exposure to SN38. Studies have shown that those homozygous for the UGT1A1*28 allele are at an increased risk of neutropenia. Although not consistently observed among trials, severe diarrhea has also been observed with genetic polymorphisms of UGT1A1. However, while the ability to test for this polymorphism is available, the low sensitivity, i.e., the ability of this test to correctly identify all patients at risk of severe neutropenia, and the lack of consensus guidelines that outline how to use the results limit its widespread use in clinical practice. However, practitioners should still exercise caution when treating patients with either a known or suspected deficiency in dihydropyrimidine dehydrogenase or a known polymorphism in UGT1A1. KTM should receive empiric antibiotic therapy and his chemotherapy should be held until both his fever and neutropenia resolve. Because he did not experience febrile neutropenia with his previous adjuvant therapy, it is unlikely he would harbor a DPD deficiency. A dose reduction of fluorouracil could be considered. More importantly, a reduction of his irinotecan dose is warranted before resuming his chemotherapy to reduce the risk of fever and neutropenia with consecutive cycles. The FDA-approved Invader UGT1A1 molecular assay is commercially available to detect the UGT1A1*28 polymorphism. If it is known that a patient has this polymorphism, an empiric reduction in the dose of irinotecan is recommended. However, its use is not generally recommended for determining reductions of subsequent doses of irinotecan after a toxic event. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 449.